Good afternoon, everyone. I'm going to present on breast cancer in Kenya. But first, why breast cancer? 10 years ago, I got diagnosed with breast cancer. And I must say I'm grateful to God because not many women in Kenya get breast cancer and live to tell their story, leave alone doing research on it, on breast cancer. And when I got diagnosed with breast cancer, I got a lot of problems, especially when I was being treated for going through chemotherapy, because nobody seems to know what I should eat. There was no much information on nutrition and cancer treatment. And as I was looking for information, I came across some information on risk factors for cancer, for breast cancer. And somewhere down the list, I found 2 risk factors that were related to diet. And that was obesity and alcohol consumption. But this was strange because in Kenya, women don't take alcohol. In fact, in this study, in my study, PhD study, I've had to apologize to many women when I'm asking them whether they take alcohol. Because in our context, it would mean I'm implying they are reckless. So I wondered, how can alcohol be a risk factor for breast cancer in Kenya? And I also realized there is not much information on breast cancer in Kenya. I gathered that this information, the information I've just talked about, was based on some research done somewhere else. It was not based on research done in Kenya. And I wondered, why wasn't there information on breast cancer in Kenya? Is it that breast cancer is not at the magnitude of being researched? And as I was asking myself these questions, I went around looking for data about breast cancer, and I found that breast cancer is of great significance in Kenya because it's second only to cancer of the cervix, both in mortality, the people who die from it every year, and also new cases every year. So if there was any research to be done on cancer, breast cancer would be one of those ones that are being researched. And I then could not avoid asking a number of questions. These risk factors that I saw were based on another research from other countries. So I had to ask myself a number of questions. Do we have the same type of cancer in Kenya as in the developed world where we are getting these recommendations from, the nutrition recommendations? Are the risk factors the same as I have just stated the situation of alcohol? And do dietary recommendations that are derived from these risk factors the same? Would they apply in our situation? So this made me go ahead to carry out a research to be able to answer these questions. And with the support from Wageningen University and in collaboration with Nairobi Cancer Registry, we went around collecting information on breast cancer patients in 4 regions in Kenya, 4 counties in Kenya. And we used the Nairobi Cancer Registry trained registrars to abstract information or to extract information from patients' files and laboratory reports from all the health institutions in those regions. And they were able to get information for 1,037 breast cancer patients. And we got some interesting results from the analysis of this information. We found that the patients who are getting breast cancer are relatively young because they are, on average, 49 years of age as compared to America, where the patients who are getting diagnosed with cancer are 61 years old at diagnosis. And then we also found that most of the women in Kenya are premenopausal. The other ones are, the ones in America mostly are postmenopausal. And if you had looked at our risk factors, the ones I had shown earlier, Obesity is also a risk factor. In that list, it's also one of the diet-related risk factor. And it's also, the recommendations that are there are saying that there are different recommendations for premenopausal breast cancer and postmenopausal breast cancer. For premenopausal, obesity seems to have a beneficial effect. For postmenopausal, it increases the risk. So if these women in these two regions are getting cancer at different ages, can we apply the recommendations across the board? Of course, we cannot. Then we also looked at another factor, a clinical stage of the disease at diagnosis. And we found that, okay, clinical stage is the level at which the disease has spread at diagnosis. And okay, it also, mostly it depends on maybe screening, because in the developed world there are screening programs. In Kenya or other low and middle income countries, there is no screening programs. But it also has something to do with the aggressiveness of the disease. So some researchers have indicated that. And we found that in Kenya, we are finding only 6% people in early disease. Stage 1 is early disease. Stage 3 and 4 is late disease. So the patients in Kenya are coming late with stage 3 and 4. The ones in America are coming at stage 1. So we cannot compare those two groups. And then it was clear that it is evident from these results that we are dealing with a different kind of disease. Risk factors are likely to be different, although we've not yet done that bit right now. And of course, it's obvious we cannot apply the same dietary or nutritional recommendations. And to just help us see this clearly, I wind up with a cultural analogy. When I came to the Netherlands first time, I was made to understand that if you're invited for dinner in a Dutch family and you're offered cookies, you're supposed to take only one. But in Kenya, where I come from, my appetite determines how many cookies I take. But when I'm here, I have to take only one cookie. So in the same way, we cannot apply the nutritional guidelines developed with research from some other place. We have to customize to those specific populations where they are being applied. So I urge all of us to go to the future and do more research in breast cancer in Kenya and other low and middle income countries to be able to customize and get appropriate nutritional guidelines for these populations. Thank you very much.